Hey, it's Elizabeth Morosco. I had a chance to sit down with Hurley Medical Center Midwives, and I was pretty amazed to learn that their focus on women's health goes far beyond just labor and delivery, including a focus on contraception and menopause and so much more. You are listening to the Cup of Kudos Show, a podcast focused on sharing content filled with insight, motivation, inspiration, and sometimes a little spunk. Today, let me introduce you to an amazing lady who's taking a lot of pride and dedication to bringing alternative health to women and making it easily accessible.
Hi, I'm Laurie Glenn. I am a certified nurse midwife. I have been such for 26 years. And have practiced in various different settings, from a whole full practice midwifery to STD testing and breast cancer screening. So midwives can do a whole lot of different things. I have a Doctor of Nursing practice degree, a Master's in Nursing and Midwifery, and of course a Bachelor of Science Nursing degree as well. That's how nurse midwives get to where they are. In terms of what we offer to women from sort of alternative types of viewpoints, if you think about the way we approach, for example, the adolescent, oftentimes mothers are concerned about their adolescent girls being sexually active or possibly worried even about them getting cervical cancer and needing to have the Gardasil vaccination. And a lot of parents are concerned, what are the best things for my daughter? And we are not here to tell them what's the best. We are here to offer all the alternatives, the risk benefits, what are the things that these different types of things are going to offer for your child. When does your child need to come in for their first gynecological exam? It's a lot different than it used to be. They used to say when you're 18, you have to get a pap smear. This is what most mothers are probably familiar with, but not anymore. You don't even need to come in for an exam until you're starting to have sex, or you're at least 21 years old if it hasn't happened yet. Pap smears are every 3 years now instead of every year, so things have changed a lot. And so being able to sit down with parents is important, but more important is that we take the time to talk to the girl, the child coming in too, because she needs to be able to have some confidentiality in these types of situations as well. So trying to find a good way to do that can be a little bit challenging, but it's important to make sure everybody understands all the options and understands that we want to empower this young woman to make good choices for her health.
It's great. It's great. And I think that if you can start a young lady off with that skill set and mindset of having everything within her to make those choices, it's actually a strong woman in the making. Yeah.
Absolutely.
So for a mom that maybe has a teen that is about to start her period and she wants to get some insight, because it is different than it was, in the 70s and the 80s when I was growing up.
Absolutely.
But if a mom wanted to come in and make an appointment with a midwife versus going to, just a traditional OBGYN doctor, what's some advice that you would give that mom for finding somebody that's a perfect fit for their child?
That's a great question. And not because not every OBGYN or every midwife is necessarily going to specialize in the adolescent, but we do have a few people in our practice who really are passionate about that. You want to have someone who's going to sit down and have that open conversation, empower that young lady, and who's comfortable with talking to young people as well. I think it's tricky because developmentally they're in different places, and how you approach a young lady. In my experience, I worked in the health department in the family planning clinic for several years, and we saw anybody from the age of 12 to 55. And those very young women are very concrete and very matter of fact, versus when they start to get a little older, a little more abstract thinking. It's a little easier to help them understand the long-term consequence of their actions. But when you get to that first part, you really want to get to that young woman like you talked about and help them empower themselves to make good decisions. After that, in terms of the parent involvement, if you feel as a parent that you need to be involved with that child's care, that's okay. But remember, all children have the opportunity to go talk to their healthcare provider without a parent present. That's their right, and that's most good healthcare providers will do that. I know my daughter's 19. They kick our regular provider will kick me out of the room so that they can have a private conversation about, because how else do you find out if there's abuse going on at home?
Right.
How else?
Right.
Sometimes your child won't tell you if they're having sex or doing things that maybe drinking or smoking or something like that, but they might be more willing to open up to a healthcare provider.
I agree with that, because I think that sometimes as a parent, it can maybe feel like an authority versus if you can have that personal one-on-one relationship with the healthcare provider and they feel like they can confide in you.
And I think that's the key, is having a relationship.
Absolutely. Even as a parent.
Yeah. And because as a provider, I think it probably takes a couple visits before you can really establish that relationship and trust, so that someone feels like they can tell you some of these things that might feel uncomfortable.
Now, for young ladies that may have irregular periods, maybe even endometriosis at a young age, do you guys help with trying to regulate, cycles through like birth control and stuff like that? Do you do that here?
We are really good at normal. And so a lot of times...
I like that phrase. It seems to be a tagline here. Good at normal.
Good at normal. And so when a young woman comes in and they maybe perceive that their periods are irregular or painful, it actually might fall within that normal range and can be, just like with menopause, corrected with good diet, exercise, rest. Nutrition is so hard in the adolescent population, but it's important. Sometimes those things can be corrected that way. And then we can go to that next step, which is sort of like low-level intervention, I would call that, meaning regulating them on birth control pills is a great way for a young woman to have more regular periods, less pain, and possibly even less acne.
Oh, there you go.
There you go.
Selling point. Acne-free.
But there are, of course, it's still a hormone, and it does change that person. So you do want to make sure that's the right decision for that young woman. And it's not always about not getting pregnant, but that's another benefit if that's going on as well. So I think that that's one example where midwives are really very well prepared to do that. Anything beyond that, though, we have some gynecological partners that we work with who can help us either guide us on what additional treatment somebody might need, or possibly even take up their care and make other recommendations.
Oh, that's great. So I'm kind of like a sidebar, different note. I'm a mom. I'm a widow. I have 2 young boys. So there's a lot of topics that I have to deal with as a mom with boys that maybe the dad would traditionally deal with. And it leads to mine. I know that there are other single dads, whether through divorce or death or separation, that are going to have a daughter or daughters. And just out of curiosity, what advice would you give these single dads that are raising these young women? And it's kind of like a 2-step dance. And I mean, sometimes, especially if periods flowing in, there may be hormonal and emotional and who knows what. What are some insights that you can give these dads?
That is a great question. I will tell you, I'm a midwife, and I was very open with my daughter growing up about her body and her period. And the first time she had her period, she was horrified and crying and like just beside herself. So no matter how much you try to prepare your child, it's still a major change in their life. And they may or may not be ready to accept it.
Right.
So I don't know that it's definitely a lot easier for a man, but I think that my suggestion would be to find trusting women. Again, back to those relationships that can be another resource. And it either can be the resource for the dad to go, like, what do I say? What do I do? How do I handle this? Or for perhaps someone that young lady trusts, that she can talk about these things to. And I think that probably for someone like that, that's going to be important to set up as soon as you can.
Right.
So you have a resource for that young woman.
So maybe even like the midwives here would be a good fit.
Absolutely.
Yeah.
Sure.
So would a parent be able to talk to you beforehand, before your meeting with their child, to find out if you're a good fit?
The parent can talk to us, but whatever the child shares with us confidentially, we can't tell them. Unless they specifically say, yes, please tell my parent that I told you that I am concerned about this or I'm doing this.
Right, right. Yeah. So you become the Iron Vault. They can be good.
Yeah.
So with so many different services available through the midwives, what are some things that you think the public doesn't know that you guys do? You know, your specialty superpowers.
I think most people are pretty versed in how we support women for pregnancy and birth.
Sure.
I think that one thing that I need to give kudos to my colleague, Dr. Brown, is who's really opened up our eyes to working with some mental health issues during pregnancy and beyond, which is a very difficult area because there's resources available to women are definitely restricted. So we've been able to establish a relationship with the service through the University of Michigan to provide some support to some of our moms having mental health issues. So that's one of the most, and Dr. Brown did some research within our own practice to show that we really do have a lot more mental health issues among our pregnant and postpartum population than that we really realize.
So when you say depression, are you talking about postpartum and is it perinatal? Okay. Is that what you're talking about, or like something that's prior to?
And oftentimes that's what it is, undiagnosed. It shows up in pregnancy. A lot of times that will bring out feelings. I just had a visit this morning with somebody who was sharing some information from her previous birth that I attended. She said all these feelings came out, and we discovered that maybe there was something in her childhood that was affecting that. So we were able to get her in to see a counselor to help her start to deal with some of those feelings for her upcoming birth.
That's fantastic. Yeah. It's like an awakening in a way after you, I guess, go through that. Yeah. Wow.
Like when I talked to her, her face just, I said, do you think that anything like childhood sexual abuse or something happened to you? Her face just went, just like lit up, like, I think that's what it is.
Right.
And so we started that conversation, and this is lots of different people need to be involved to help her deal with those feelings so that when she gets to her birth, hopefully, she's empowered to trust her body and trust herself and trust her mind to accept this as an experience that is going to empower her and not frighten her.
And I think it's one of the beautiful things about the human factor is when we can get people like yourself tied in to help people work through these kinks that sometimes we can't even see ourselves. We've become this society of trying to be self-diagnosing and everything and know everything off WebMD.
Dr. Google.
Yeah, Dr. Google can be a very evil, very, very bad guy. But this is the thing, though, is being able to connect with that real human factor and you being able to see that. That's where you're stepping beyond just like the, traditional OBGYN role and really connecting with somebody, I think, on a emotional and spiritual role.
Yeah. And I think that we do that in all areas. I think people are really not aware that we follow our women for their contraceptive needs, their menopause needs. I was in practice at Hurley in the 90s, and I had mother-daughter pairs who would come in because people were having a hard time back then finding a provider who would not give them hormones. They didn't want hormones. They just wanted to come in and complain about their menopause, basically. I had a thriving practice and most of my women in that practice were the mothers of the women who I had taken care of having a baby.
Wow.
So I think that's something that
That's
not
cool.
everybody understands. And I think that the women, now that I'm that age of menopause, I think a lot of us feel like, just like you said, we have to take care of ourselves and no, I'm not going to do this.
Sure.
But I think it's important to have, someone to go talk to and to talk, is this normal? And I feel really out of sorts. And is this menopause or am I having a heart attack? You don't know,
Yeah, exactly.
So much of that is,
Yeah, I started down that road. It's a little bit beastly. And I probably need to set up an appointment with you ladies. But yeah, I had no idea that you can internally combust like that and completely sweat.
We're laughing at the internal combustion.
She's laughing with me,
It's
not
perfect.
at me. Yeah, raindrops in my bedroom. It was awful. Nobody told me this stuff.
Yes.
I think I've said that a couple of times today. Nobody told me till you go through it.
Yeah.
But I think that as women, when we go through things and we take those experiences and share them with other people, that's how we create a better scenario for the next person that's going through it. And that's really one of the reasons why we do things like the podcast and the magazine, is to let people know, hey, you're not alone. What's the phrase you keep using? This is normal.
Yeah.
The normal.
Normal.
Yeah. So
Normal's got a pretty wide range. And
Yeah.
I think that it's really easy in this age to look for a disease you don't have and be really scared, you know?
You've probably heard it a couple times.
Yeah.
Yeah, it's kind of like my kid. What's this spot? What's this that? Learning and growing. So, real quick, I want to talk to you. You brought up contraception, and a lot of things have evolved.
Yes.
Over the decades. So before we'd have, condoms and rubbers, and what are some of the other things that are available right now? Like, is it the ring?
Well, there's a lot of different things available. What I think is very wonderful is that our teen pregnancy rate is low as it has been in probably 25 years. Wow. And I attribute that to a lot of different things. But one of the things I think that has made it so low is the availability of effective long-acting contraception that is easy to use and available to young women. So you can get an implant in your arm that lasts for 3 years. You can get a very small IUD now for a young woman who's never had a baby that lasts for 5 years. You can get another type of IUD. Usually that one's a little bit better if you've had a baby, but we can actually insert those to women who haven't, using some different techniques that lasts for 10 years. The ring you're talking about is something you don't have to worry about doing every day. You, every 3 weeks, remove it and have some bleeding and then put another one back in. There's the patch is another birth control option. I don't see that used as often as it was, but that's a once a week type of thing. So I think that having a lot of hormonal contraceptive available in those longer acting types of deliveries really does help to them be more effective, because when you're having to take a pill, I don't know if you ever had to take the pill, but taking a pill every day, it has to kind of be at the same time. You miss one, you bleed, and it's just not the greatest method, but it is still the most popular. In terms of barriers, you can still get diaphragms. We just got a little kit.
They still make diaphragms.
Yeah.
Okay.
I was happy to hear that because I think it's a good option for a lot of women. And of course, condoms are good for preventing STDs for the most part. They're nothing's 100% except for the baby aspirin between your knees, meaning not having sex. So
don't do it.
But I think so. Those are some of the things that are available to people now, and I think because of also, I think young people are more prone to using technology to sort of discover each other without sex. Can I just say that in a politically correct way?
Yeah.
So there's a lot of
little risky phone and text
like,
time is what she's saying.
Is it terrible that they're sending each other pictures? They're not getting STDs. They're not, and of course there's all that self-respect stuff that we need to be careful
One word
about.
of caution, though, to say, especially if it's people that are underage, because this just recently happened with a school. If you are underage, whether you're receiving it or sending it, if it's a photo of somebody that's underage, I believe that it's considered distribution of child pornography.
Yep.
So I think they need to change. Well, that's my own opinion. They need to change some stuff because kids are stupid.
Yeah, it's so tricky.
I've got teenagers. Fortunately, that hasn't come down our road. But
really
it is tricky, and there's a lot of sick stuff that's going on right now. But so I just wanted to make that note.
Absolutely.
If you are a teenager, you are under 18, do not
it.
do it. Do not.
Nope.
Do not. So yeah.
But I just think that there's different things people are doing now. And
absolutely. And I think that even with online activity, this is actually a really important part that you're talking about, because it does even affect later on, even different things like intimacy, and we have been seeing, we're talking about the midwives, but we've seen an increase in addiction and pornography, and then impacts that later has with personal relationships.
Absolutely.
So
There's benefits and risks to everything. So
absolutely. So I guess one of the our positive parts is if we see a reduction in teen pregnancy. Take a picture instead of the action.
But there needs to be a middle ground for everything.
I agree.
Balance.
I agree. Absolutely. And I don't know all of the answers. I'm still, I think with technology, everything's evolving so quickly, and things are changing. Probably even the way you communicate with your patients, and your clients, through.
Get a text about your appointment.
Oh, you guys do that?
Yeah.
Yeah.
You can look online to see what your lab results are now.
See?
And you can see what we wrote about you too.
Yeah.
So, yeah.
So be nice. No, but those are things that literally can have a positive impact on your own healthcare. So, I think that you guys have, is it a portal system or something like that where you can pull up all of your appointments, your meds and stuff like that. So, we'll use it to our advantage on getting everybody a little bit healthier. So are there any other things that you really would want our listeners to know about the benefits of working with a midwife?
Well, I think it's not for everybody because it does require someone to take some action to embrace being empowered. Some people aren't necessarily as comfortable with that. They prefer having more direction. I don't know if that's the right way to say that, but you know what I mean? Some people are a little bit more used to having someone else kind of guide them more directly, whereas we're going to give people a lot of choices. Some people don't like that. Some people like to be told what to do.
Right.
But those choices are important, and trying to make sure that people feel comfortable with that, certainly. And then obviously people who have significant chronic health conditions and so forth are not going to be suitable for midwives. We would certainly want them to get the appropriate medical care to make sure all their needs are being met.
So you would meet with them in advance to make sure that it's a good fit and you can provide what they need. That's wonderful.
Occasionally we do have people that are pregnant with some higher risk factors as part of their pregnancy, and we work very closely with our maternal fetal medicine service at Hurley Medical Center to determine whether or not these people are appropriate to stay with midwife care. Because sometimes the issue might be, let's say there's an issue with a baby, might have an anomaly. Does that person need a high-risk doctor? Probably not. We're going to watch things closely. The emotional support they'll get from a midwife might be the better thing for them. And we really work closely with shared decision-making with those maternal fetal medicine doctors on what's the best thing for those patients.
Right. That's one of the things that I really love about Hurley Medical Center is knowing that they have the best doctors, especially during a crisis pregnancy, available, but to be able to have a more natural alternative in cases where it's not a crisis, I think is phenomenal. So, well, thank you so much for meeting with us today.
Did you want me to talk a little bit about the other midwives that we have in the community?
Oh, yeah, actually that would be great.
Yeah.
One of the things that we were talking about earlier is that not all midwives are the same. So could you go into that a little bit?
So there are certified nurse midwives in Michigan is who you will encounter in hospitals. So to be a certified nurse, to be a midwife in a hospital, those are all certified nurse midwives. Some certified nurse midwives, so they have a nursing background, a master's degree, and a certification in midwifery from the American College of Nurse Midwives. Some of those midwives will do home births or out-of-hospital births in birthing centers as well.
Okay.
There are also another group of midwives in Michigan called certified professional midwives. Their background does not include nursing necessarily. It's various different ways to get to that certification, an apprenticeship model, some formal training, classes, and so forth. In the state of Michigan, beginning in sometime this summer, those midwives doing out-of-hospital births will be answering to their own board at the licensing bureau in Michigan. So there's now a Michigan Board of Midwives, just like we actually sit on the Michigan Board of Nursing because we're nurse midwives. But there is a Board of Midwifery now that was established. It was a law that was passed under the what's the last governor's name?
Schneider.
Thank you.
It's okay. I do
Under the last administration, there was a law that was passed to license midwives who do out-of-hospital births because there were a lot of concerns about how if something was not going well, how that patient came to the hospital, whether or not an appropriate report had been given, whether or not that patient had the appropriate risk to be able to have a baby at home. And so this has been about a 3-year process getting this board established. And what it really does is it gives the citizens of Michigan the opportunity to make sure that their midwives who are doing out-of-hospital births have the appropriate credentials, education, training, and are following the appropriate protocols for risk factors for having a baby at home.
Yeah, because it would seem like that would be where there's
Right.
higher risk is being at home, so you should be well qualified.
Right.
Yeah.
So that's still in the process of
Interesting.
getting established.
I didn't even know that was something that was in
So
the
if you
works.
look
It's
at-
interesting.
If you just search Michigan Board of Midwifery, you'll see some of the documentation.
Okay.
That is not officially done yet.
Right. It's in the process.
It's in process.
Breaking news.
I sit on the board
This
of
is good.
nursing, and it's really interesting how long it takes to establish
Right.
rules for the laws that get established. But they're being very careful, and a lot of organizations have had a say in what those rules should be. Obstetricians, and of course the midwives who do out-of-hospital births. The American College of Nurse Midwives Michigan section has contributed to it as well.
Oh, that's
So there's a
great.
lot of different things. And so what has happened in other states where this type of thing was established, there's a little uptick in people having babies at home, but also there is more collaboration between those out-of-hospital midwives and the hospitals where those folks might wind up if they have a complication. Because
Interesting.
right now there's no really rule that has to happen. So in the end, the public is going to be better protected.
Right.
So
right.
and we'll see how this goes in Michigan. Michigan's like a little late coming to the game for this, but not as late as some. I think we're like about half the states have this kind of licensure right now. So the hope is that if by doing this, we're going to set a standard for the out-of-hospital birth and help people understand that. Because sometimes whenever I've seen a really bad outcome from that kind of situation, it's usually because the patient probably was more high risk than was appropriate for a home birth. But there's a lot of controversy around it. It's a big change, a huge shift in how we think.
Right.
So there's a lot of work that needs to be done, but maybe bridging some of those gaps will eventually lead to a really good, like in Chicago, Illinois, there's a good system there that's very much based on this. And if you have your baby at home, you're going to do that. You're going to see a midwife that has a hospital-based practice, and you're going to see, and then an obstetrician will actually review the record, and everybody kind of is on the same page that this person's okay to have their baby at home.
Right.
And
We had a family friend that actually was planning on delivering their baby at home, and she had a midwife. It's my mom's best friend's daughter, so she's half Native American. Fortunately, one of the family members was really encouraging her to go to another doctor to have it looked at. And in short, it's a little bit of a long story, but the baby had the cord wrapped around its head. They had spotted some stuff prior to her labor and delivery, and they were encouraging her, this might not be the one to do it. I don't know if it was through her blood pressure or whatever was going on. Fortunately, she listened, and she was in the right place where she needed for that pregnancy, so, but she still was able to do her natural birth. But yeah, she was actually going to deliver in a TP, but that's a different story for another time. No, I'm not making this up. She's a beautiful person, but
that's interesting.
But I think it was her father that was saying, I want you to go to the doctor to have this looked at, make sure.
okay.
And they found something that was her symptoms that were reading. There was distress going on, and this probably wasn't most ideal. So, but I know that there's many times where people have delivered at home, and it's beautiful and it's wonderful.
And we don't ever hear about that. You hear a lot.
The scary
if
stuff,
there's
right?
something that happens in the media, it's usually a pretty extreme case.
Yeah. And being able to do what I think you're most comfortable with is wonderful. But what I really like that you're saying is through this, they're creating different layers to make sure that baby's safe and mom is safe and everything's that they may potentially need are
Right.
put in place.
Right.
Which
And I think
is-
the other thing it does too, for those of us who still, I like being in a hospital, because for me, my experience, there's two reasons I love being in a hospital. One, the most serious consequences of having a baby is possible hemorrhage. And if I'm in a hospital, there's a cart full of medication and 7 other people who can come and help me deal with that. And so I think from that perspective, I feel more comfortable being in a hospital. The other time is I've done about, 800 and some births in my career. It's not as many as some people because I haven't done births my whole career, but
Just getting to that 1K.
yeah, before I retire maybe. But when there have been probably 5 babies that came out that I had absolutely no idea that were not going to be in good shape. They didn't necessarily give us a clue during labor, or they had an undiagnosed problem and they came out with the problem. And I have been so grateful that I could pick up a phone and have a neonatologist in the room within 30 seconds to help deal with those types of issues. So for me, but then you have to remember the types of people that we're taking care of in the hospital are inherently going to have higher risk issues, hopefully with this system, the way it's set up. So therefore, they're probably going to be at more risk for those types of things anyway. So it's,
And that's one of the things that I really like about the pediatricians and just the whole NIC unit, all of the healthcare options that are available for children just coming into this world at Hurley. And I mean, we're really lucky where we don't have to travel, all the way down to Detroit. It's right here in mid-Michigan. Yeah. So, I mean, it's phenomenal. And it just seems like it's the ideal situation to be able, for me, to be able to do a natural birth with a really supportive coach, but in the background, in case all hell breaks loose, there's that support team waiting in the trenches. Like, we got you.
okay.
Yeah. So, but this was wonderful. I do appreciate you taking the time to, share all the differences between midwives and just all the different options of healthcare from a young age to menopause. And maybe later on, another time, we can talk a little bit more about menopause and share some tips for 50, 60-year-olds.
This is our girl.
So, yeah. Okay, well, thank you so
Thank
much.
you.
And in the meantime,
Nice
happy
talking with you.
spring, happy baby delivering season.
Okay, thank
take
you.
care. Bye-bye.
Bye.
Thanks for listening. And for more daily insight and inspiration, visit us online at cupofkudos.com. And you can find us on Facebook at Kudos Magazine.